Today our topic is coarctation of aorta, and we're going to limit ourselves to the clinical presentation and diagnostics. Now, just a small thing to remember in coarctation is, remember the rule of 7 with coarctation. Coarctation is constituting 7% of all congenital heart diseases, and it's the 7th most common congenital heart disease. So this is where the rule of 7 works for coarctation. And the incidence is up to 3 cases per 10,000 births, where it is considered to be more common in males. This is especially more important for neonatal or infantile coarct. However, in adolescents, where abdominal coarctation is a little more commoner, then at that stage, it's more common in females than in males. The recurrence risk, as much as coarctation is concerned, is a shade higher than other congenital heart diseases. And this goes along with this recurrence pattern of the left heart lesions. So coarctation, the recurrent risk is 6.5 to 10%. 10% is almost twice the recurrence risk for a general congenital heart disease. And it is usually seen across the ages. Unlike other CHDs, coarctation is seen across the ages. It can be seen in the neonatal period, it can be seen at the adolescent period, and every age is very peculiarly having different clinical symptoms. Also, remember that coarctation can happen in isolation or it can happen in association with other defects. So, which are the common associated defects? The most common, I would say, is the bicuspid aortic valve and a ventricular septal defect. Bicuspid aortic valve is seen up to 60% of coarct babies in younger age group and 30% of children in general with coarctation. And the other lesions which are seen commonly, obviously, is the patent ductus arteriosus, or it can be seen along with other complex congenital heart diseases. The syndromes, there are few syndromes which are associated with coarctation of aorta, and the most commonest association is Turner's. However, from the other side, if we take 100% Turner's, only 5% will have coarctation. And hence, it's extremely difficult in a newborn period. When you have coarctation, is it important for you to send a karyotyping for every single child? I don't think that's the rule, but always have an eye to see if there are any associated phenotypic features to suspect Turner syndrome, because missing a Turner's 2 ways can harm us. One is related to the surgical risk factor. Turner syndrome and coarctation will have a shade higher risk factor in terms of tissue friability. And to that extent, that coarct balloon dilatation is sort of a relative contraindication in Turner syndrome. And second is related to the counseling of the family, that the disease is not just related to the heart, but it can extend much beyond that. The other few syndromes which are common with coarctation includes Williams syndrome. Williams syndrome can have renal artery stenosis or coarctation, neurofibromatosis, and Sturge-Weber. These are rare. Cerebral aneurysm is an association which is important for us to understand, and this is something which makes it important for us to follow up the coarct babies lifelong. Along with systemic hypertension, which is also in association with coarctation, cerebral aneurysms predispose these children to cerebrovascular accidents later in life. This is just a summary. So we know that up to 10% of the babies in the second generation can have a repeat coarctation, and the associations most commonly include Turner's, bicuspid aortic valve and a ventricular septal defect, and systemic hypertension and cerebrovascular accidents. So now with this understanding, we will move on to the definition of coarctation. So coarctation actually was derived from the word coarctare, which means contracted. So coarctation just means that it is a narrowing of the aorta. This is congenital in origin, and it usually is seen in the proximal thoracic aorta. What happens inside the lumen is that there is some amount of medial thickening and infolding of the intima and the media. The most common site for narrowing is considered to be a juxtaductal stenosis. However, coarctation may extend beyond the juxtaductal area. It could be a long segment or it could be associated with hyperplasia of the transverse aortic arch, and sometimes also there could be stenosis of the abdominal aorta. Most commonly, there is a post-stenotic dilatation where the segment after the narrowing has dilatation in the part of the descending aorta. And secondarily, we see collateral vessels that connect the arteries from the upper part of the body to the lower part below the level of coarctation. And these collateral vessels are commonly seen when the lesion is not severe, and also these collaterals will take few weeks to develop. Now we came into the understanding that you can have coarctation with hypoplastic arch. So how do you define hypoplastic arch? You need to compare the measurements with the ascending aorta. So you start with the isthmus, which is the segment between the ductus and the last aortic arch vessel. This isthmus is if less than 40% of the ascending aorta, or if the distal transverse arch is less than 50% of the ascending aorta, or if the proximal transverse arch is less than 60% of the ascending aorta, then we would define this as an hypoplastic arch, which will further have implications related to the management. Now coming to the embryology, we know that it has the arch development happens predominantly from the fourth aortic arch. However, embryologically there is a problem either in the fourth or the sixth aortic arches on the left side. So you can see here, this is the sixth aortic arch, this is the fourth aortic arch. The sixth aortic arch medially gives rise to the left pulmonary artery and distally gives rise to the ductus arteriosus. And the fourth aortic arch gives rise to a significant part of the left aortic arch. So there are two theories proposed for causing coarctation. One is the ductal tissue theory. That means that the smooth muscle which is present in the lateral distal aspect of the sixth aortic arch migrates into the corresponding aortic tissue, because of which you have a narrowing which is produced, which is typically seen as a significant shelf in the isthmic area. The second theory is the flow theory or the hemodynamic theory, which says that, for example, if you have reduced flow across the ascending aorta because of severe aortic stenosis, then the reduced fetal blood flow causes a reduction in the volume and reduction in the size or growth of that isthmic area. Initially, we had this traditional classification of the preductal and postductal, which is not commonly used now, and we use the word juxtaductal. The preductal form was where the coarctation was proximal to the ductus arteriosus, and the postductal means it was distal to the ductus arteriosus. The preductal commonly presented early in life and the postductal later in life. And as we understand, if it's preductal, duct is supposedly going to be supplying the descending aorta, whereas the same thing will not happen in postductal. However, now most of the coarctations are considered to be juxtaductal and ductal dependent. Now, what happens when you have coarctation of aorta? So there are both the ways impact. One is related to the back pressure and second is related to the forward output. Now, in coarctation, as we understand, PDA is the one which sustains the systemic circulation. So once the PDA constricts, what happens is that we have increase in the afterload for the ventricles. The left ventricular hypertrophy will cause increase in the left atrial pressures, which will cause the PFO shunting left to right and secondary right heart dilatation. This is very commonly seen after birth in neonates with coarctation. So in spite of having a left heart lesion, we have right heart dilatation, which is so peculiar of coarctation. In pregnancy, the theory explained for right heart dilatation is a shade different. And that is because it is a parallel circuit instead of a series circuit. Postnatally, once the PDA closes, the distal perfusion is affected, and hence we have reduced systemic perfusion to the abdominal organs and the lower part of the body. So in a diagrammatic representation, if we see this, we have the coarctation here, because of which we are going to have some amount of systemic hypertension. The reasons for systemic hypertension we will see in the next slide. Because of which we have increased left ventricular afterload and increased left atrial pressure, torrential shunt of PFO left to right, and right heart dilatation. Once the duct constricts, we have reduced systemic perfusion. If this coarctation is not very severe and it goes unnoticed, then we tend to have collaterals from the proximal segment to the distal segment after the coarctation. And we will understand that the symptoms which are predominantly seen at a younger age are because of a combination of back pressure and pulmonary edema, or ductal constriction and reduced pulmonary blood flow. And hence you have a combination of cardiac failure and poor perfusion, shock, and acidosis. The collateral circulation was first described very interestingly in 1940s. So collaterals were picked up as early as 1930s, and there were 9 cases discussed in this article, which was published in 1941. The understanding about collaterals now is almost 70 years old, and let's see from where the coarctation gives rise to collaterals. Remember that if it's less severe coarctation, the collaterals tend to develop, and collaterals will take first few weeks to develop. It takes few weeks to develop over time. So from the arch of aorta, we have the subclavian artery and the internal thoracic artery, and then the anterior intercostal arteries, which will give collaterals retrogradely into the posterior intercostal arteries, and then finally into the descending thoracic aorta. Remember that the first and the second vessels do not participate because they are branches of the thyrocervical trunk and not directly from the aorta. Hence, you have the collaterals from the 3rd to the 8th or 9th ribs. These posterior intercostal arteries will participate in collateral circulation. And this is how the collateral circulation will look. They are branches of the internal thoracic artery, the thoracoacromial, thyrocervical, the vertebral and the spinal will throw collaterals into the intercostal arteries and the epigastric arteries. And these collaterals are then finally visualized as older kids on chest X-ray as indentation seen. Coming down to the second understanding of systemic hypertension. Now, as we know, we have a mechanical obstruction, and hence we think that mechanical obstruction itself is the cause for systemic hypertension in coarctation. However, there are few things which are not very well explained just based on the theory of mechanical obstruction. One is that you have a lack of relationship between the degree of stenosis and the degree of hypertension. That means children who have significant coarctation may not have that much degree of hypertension. Second is you have increased peripheral vascular resistance even in the lower limbs, that is distal to the obstruction. Third is, even after the surgical correction, your blood pressure in the upper limb might still not be normal. So your hypertension persists even after correction of coarctation. So based on that, the thought process was, are there other reasons for systemic hypertension? And the possibility is, one, focusing on the renin-angiotensin mechanism, where because of coarctation we have reduced renal blood flow, which causes activation of renin-angiotensin system, and this probably contributes to hypertension. And third possibility is due to activation of the central sympathetic nervous system, because of which it is a common policy to consider beta blockers in a pre-operative state so that the post-operative and the peri-operative control of hypertension becomes a little smooth. The clinical presentation, remember that it does not depend upon the site of coarctation. It depends upon the severity of coarctation. So the timing and severity of presentation depends upon the severity of coarctation, and also in newborn period, the extent of ductal patency, the rapidity of ductal closure, and also the pulmonary vascular resistance. So what all decides the clinical presentation? The severity of the lesion, the extent of ductal patency, the rapidity of ductal closure, and the pulmonary vascular resistance. And with this, if the severity is there in terms of it being a severe coarctation and the duct is closing, then we will have neonates presenting with poor feeding, tachypnea, heart failure, lethargy, and also shock and acidosis once the duct completely closes. And here it shows the importance of prenatal diagnosis, because in presence of duct being patent, coarctation might be missed before the baby gets discharged along with the mother after 48 hours. And then later, once the duct closes, these babies can present in a very sick condition. Prenatal diagnosis has its own role, as a confirmed diagnosis may not be possible in fetal life. You can have a fetal echo which looks completely normal and the baby presenting with coarctation postnatally. However, there are few signs which could be considered suspicious of coarctation antenatally, and it has its own sensitivity and specificity. The second is the role of newborn pulse oximeter screening in coarctation. If it is going to be a duct which is sustaining systemic circulation, we are going to have some amount of desaturation in the lower limb. Sorry. And hence the role of pulse oximeter in the upper limb and lower limb. Also remember that children with chromosomal defects can have coarctation. And hence, children who have suspicion of Turner, or when children present in the adolescent age with they present with adolescent age with short stature, always try to rule out coarctation of these babies. But what happens if the children have less severe coarctation? Usually present later in childhood with murmur or systemic hypertension. This is an important message that every single child entering a pediatric OPD or a pediatric cardiac OPD should probably have a blood pressure recording done in the upper limb at least to rule out systemic hypertension. There are babies who get picked up just when they walk in the pediatric OPD based on systemic hypertension. There are children who might complain of frequent headache or leg pain on exertion, and then on evaluation get picked up with coarctation. So these children commonly present in their first or second decade. Now, examination findings. Coarctation is one disease where just clinical examination can clinch the diagnosis of coarctation. There are very few heart diseases which can do this. Other examples are, for example, if it's a multiple heart sounds, you would think of Epstein. If you have a pericardiography, you would think of a pericardial effusion. If you have clinical features of upper limb, lower limb, blood pressure discrepancy, you would think of coarctation. So what happens is that you have upper limb pulses which are bounding and lower limb pulses which have reduced amplitude. The rate of rise is slow and there is a late peak and there is a low pulse pressure. So typically, there are four characteristic changes which are happening in the lower limb pulses. One is that it has reduced amplitude. Second is the peak is late. Third is that the rate of rise is slow. And fourth is that the pulse pressure is low. Remember that the onset of pulses which are happening, the radial and the femoral, is together. However, for the femoral, the percussion wave is so low that what we feel is the tidal wave. How do you define coarctation clinically? In milder forms of coarctation, systolic pressure gradient of 20 or more between the upper and the lower limbs would clinch the diagnosis. On cardiovascular examination, you might find the LV impulse which is increased, and this is typically in older cohorts where you have left ventricular hypertrophy. You click, which is typically a bicuspid aortic valve, where the click does not change with respiration, and the click is heard in the left second sternal border and apex. And you might have a short systolic murmur in the interscapular area because of coarctation. Continuous murmurs are very rarely heard because of collaterals. This is just a diagrammatic representation, and this is just important to go through this so that you have a visual picture of coarctation. And this is what we described in the previous slide, where the pulses in the upper limb are bounded, and the pulses in the lower limb have a slow rate of rise, a late peak, reduced amplitude, and low pulse pressure. If you see this, you can see here that the femoral artery and the brachial artery pulsations, if you chart a graphical representation, here is the peak, which is lesser, the amplitude is low, the rate of rise is slow, and the pulse pressure is also low. And as we understood, these are the tidal waves which are felt in the femorals. The starting of the pulse is happening at the same time for the femoral and the brachial arteries. Now coming down to the investigations, chest X-ray, as we understood, in a younger age group may not show something. However, if you have a child with ventricular dysfunction and pulmonary venous congestion, we might see cardiomegaly and pulmonary venous congestion in the lung fields. In older age group, we might see the characteristic classical sign 3 here, which is related to the indentation of coarctation of aorta, and then the dilatation which is present in the post-stenotic area and pre-stenotic area. And additionally, as we understood, we could see the notching of the ribs, typically from the 4th to the 8th ribs, because of dilatation of the intercostal arteries, and characteristically it is bilateral unless and until we have an aberrant subclavian artery. So this is X-ray. ECG again is not very specific, but in older age group you might have left ventricular hypertrophy. In younger age group, ECG may not add to any information. Now, echocardiography, one important message I need to give you is the subcostals are very, very important. Sometimes if it's a low thoracic coarctation, you may not pick it up from suprasternals. So subcostals, when you do a tracing for the descending aorta, you will get a tracing which is not normal if the coarctation is more than mild. So always start your echo from subcostals, and you might pick up a subtle left ventricular hypertrophy. In apical view, also you can see here that the left ventricle looks hypertrophic. You might see a PFO, which is shunting left to right with turbulence. An incidental pickup of a bicuspid aortic valve in long axis. I think the images have a problem. Maybe I can go back to the main file and just open up here. So the sequence of images may not be right, but as we understand, we will have the typical double envelope sign. So this is from the segment which is proximal to the aorta, and this is from a segment which is distal to the aorta. And ideally, you are supposed to remove V1 square from V2 square so that we get the final calculation for coarctation tracing. Now remember that a significant coarct is indicated just not by the peak gradient but by the diastolic spillage and increase in the mean gradient. So if you have a peak velocity of 60 but no diastolic spillage, then it's going to be a mild to moderate coarctation. But if you have diastolic spillage, then this coarctation is going to be moderate to severe. As we can see in a parasternal long axis, the parasternal long axis will show left ventricular hypertrophy. Okay, Kavita, I think there's a problem with the images. The valve, please try to look for coarctation of aorta. You might see some amount of turbulence here in parasternal short axis coarctation. So you might get a chance to suspect coarctation in other views. Also, in suprasternal view, the whole length of the arch is important to rule out a hypoplastic transverse arch, and the coarctation needs to be delineated well here. Remember that you might miss a coarctation in presence of PDA, and hence a very good examination of the arch will tell you whether you have an anterior shelf, you have a posterior shelf. Just having an anterior shelf may not be much to worry about it, but if you have a large PDA, I would follow those arches till the PDA becomes smaller to make sure that it has not cinched out that ischemic area and produce any coarctation. You can also examine the descending aorta just distally, measure the length of the narrowest segment and also the distance from the left subclavian to the narrowest segment to fine-tune your management. And then the gradients, typically as we discussed, we might have a diastolic spillage. Okay, I guess now it's playing. Now here you can see that this particular video I have kept because the turbulence in the, you can see this turbulence which is seen in the arch. So this could be either a coarctation or it could be related to a duct which is right to left. Whenever a PDA is right to left, it can be related to just a primary pulmonary hypertension, or it could be related to a proximal coarctation which is not profiled in this view. So it's very important to have a clear diagnosis. Sometimes we do end up having a CT scan for such conditions, but CT also has its own limitations. So I personally feel that it's important that we pay a lot of attention to echo pictures and develop an expertise over time so that we can decide whether is this child needing coarctation intervention. The message is that always check for descending aorta, Doppler, below the diaphragm. Look for indirect signs. Do not miss this. If your LV looks hypertrophic, if you have dysfunction, if you have right heart dilatation which is unexplained, if you have severe PH in the newborn period which is not becoming better, or if you have a PFO which is torrentially shunting left to right. So these are the few situations where you should strongly suspect coarctation. Check for associations like a parachute mitral valve, a supramitral membrane, a bicuspid aortic valve. Always see the whole length of arch and descending aorta and check for PA pressure. So these are few things. When would you suspect coarctation? Remember that coarctation on its own management is not going to be just limited to neonatal period or infantile period. Lifelong follow-up is important because of three primary reasons. They can have persistent hypertension, they can have recoarctation or restenosis, and they can have aortic artery aneurysm. Do not forget cerebral aneurysms also. The message is that most babies with coarctation appear well in the first 48 hours. Suspect coarctation with, in infants with chromosomal defects. Always check upper limb and lower limb saturations in a newborn period. If you have fetal echo which says that right heart is dilated, then always make sure that you are careful monitoring these babies for a few days in the NICU. RV is the systemic ventricle in fetus, and hence any left-sided obstruction will produce right ventricular dilatation in fetal life and early neonatal period. And in a newborn, If you have a significant right ventricular hypertrophy with extreme right axis deviation, which is more than 180 degrees, then you should suspect coarctation. Palpate brachial and femoral together. If it's a mild to moderate coarctation, you will still feel the femorals, and hence you will miss mild to moderate coarctation, but try always to palpate the radial and the femoral together to appreciate a difference. So for this normal babies, you should always feel the radius and femoral together. Blood pressures need to be recorded in both the arms and one leg. And remember, coarctation counseling, lifelong follow-up is a must. I think we will end today's session today. If you have any questions, feel free to ask. Coarctation is a